We're ready to go?
Yes.
Great. So we've got all of our MOT colleagues on, and I'm delighted to be able to introduce Dr. Kathleen Sheehan, or Katie to those who love her. She's going to talk to us today about delirium and what's different in COVID-19. And there's nobody better that we could get. Most of you probably don't know this, but Ontario Health, the newest incarnation of Health Quality Ontario, is going to be releasing delirium standards within this month. And Katie has been part of the advisory committee tasked with developing those standards. She has also been very involved. The internal medicine side of the house will know better probably than the surgeons, but there's a fabulous project called Gemini that is looking at using big data to analyze general internal medicine experience to understand a number of issues. And Katie is part of the leadership team in developing a project that's using artificial intelligence to be able to generate novel insights and pathways for care around delirium, and in particular, to be able to use the data that's in the medical record to predict the development of delirium, which would be a real game changer, as well as to identify delirium kind of through the numbers, which would be so helpful for poor nurses who are otherwise destined to do CAMs and not always find them that helpful. So Katie is going to talk. She'll tell us a little bit more of her learning objectives today, but she's going to bring us up to date on COVID-19 and delirium.
Great. So thank you, Susan, for the warm welcome, and also to all of MOT and transplant. And I'm really excited, as Susan mentioned, to talk to you about delirium today. In terms of disclosure, as Susan mentioned, I have a couple of grants focused on a few different projects. The larger one, the Collaborative Health Research Project, is that Gemini data-focused study looking at delirium. And I also lead our new Clinician Scholar Program at U of T Department of Psychiatry. And I'm a little bit really interested in delirium, and especially how things have evolved with the pandemic, and was involved in writing a rapid review really of presentation, pathoetiology, and management of COVID-19 in adults. So our objectives today are to think about how do we recognize the signs and symptoms of delirium and how this might be different during the pandemic. Think about how do we study this, because it's a new phenomenon as we're all learning how to deal with different elements of care during the pandemic, and apply the current literature and research to our clinical situation. And that's pretty novel, because there's not a lot of places that do transplant like happens at UHN. So I'm going to start with, I'm going to try and have a little bit of interactivity, and so people can jump in or put some comments in the chat, and I will do my best. So delirium is one of those things that I think when you work in healthcare, you know it's common. We see delirium all the time. We know statistically it affects up to 50% of older adults in hospital. We know that it affects up to 80% of people in the ICU, but it's not something that gets a lot of attention, either in the hospital or outside. But with the pandemic, we have seen a lot of delirium mentioned in the press. So the New York Times, how many people read the New York Times? You can try and put your hands up, has had several articles. One entitled, "They Want to Kill Me. Many COVID patients have terrifying delirium." It's been called an epidemic within the pandemic. And articles about altered mental state in individuals with COVID. And this has happened all across the world. It's mentioned in Forbes magazine and the BBC as well. And so this is something that's really, I think, caught the attention of people, and we'll talk about that a little bit, that this illness that we really thought a year ago was mainly focused on the respiratory system has this potential to impact our brain and minds. Has anyone read anything in the lay press outside of the medical literature about delirium or altered mental status? Well, I don't know if you have your hand up or, yep, go ahead, you can unmute yourself.
No, sorry, I was just saying, yeah, I've read a lot of this stuff, and it's, I don't have much to comment because.
We'll learn about it together, but I think it's really interesting that there's something about this that's caught people's attention. There's a few kind of mini medical documentaries online as well that people have forwarded me to. So our learning objectives today, or we've gone over, but we're going to start by talk a bit about delirium in a pre-pandemic world. So just to make sure that we're all on the same page, there are lots of different ways to define what delirium is. This is a definition that's used by Alistair McCulloch. He's from the UK, a delirium researcher and geriatrician. And I think this is one of the definitions that makes the most sense to me, that delirium is a rapid deterioration in mental functioning, and it is triggered by a physiological event. So acute illness, injury, surgery, medication, and or other substances. And so you can see how this definition of rapid deterioration with a clear trigger differentiates delirium from something like dementia that has a more gradual and insidious onset and is a neurocognitive or neurodegenerative process in itself, so that there's not necessarily a trigger with that. And it also differentiates delirium from something like a primary mental illness as well. Again, there's lots of different ways to diagnose delirium, and I'm happy to make the slide set available for you. So we have diagnostic criteria for delirium, and those are in the DSM-5, which is kind of like our the Diagnostic and Statistical Manual in Psychiatry. We have International Classification of Disease Criteria, so ICD-10, which is what most of the world uses for diagnostic criteria, and this is what's in our hospital administrative data sets. Our large administrative data sets at CIHI, the Canadian institute that gathers all of our administrative data, uses the ICD criteria. And then on the right here, we have the stuff that we see in clinical practice. So what are the symptoms that are associated with delirium? We have an acute onset of mental status that fluctuates over time. So you have people who have periods of lucidity, and then they can seem quite confused. The key features of that confusion tend to be things like disorientation. So not knowing where you are or when it was, or that you had your transplant surgery a week ago, right? Being disoriented to those particular features of time and place. Being inattentive. So when you go to talk to a patient, they look like they're caught up in their own world. They're picking at their gown. They're looking at their name badge. Or you're starting to have a conversation, they go off on a different topic. That inattention is very common. And we test that often by asking people to do relatively simple tasks, like give me the days of the week backwards or the months of the year backwards. So something that, you know, most people would be able to do, but is challenging in it to do it backwards. A little bit less rote, requires that mental ability to focus. And that's what people are missing when they're inattentive. We see psychomotor disturbance as well. And I think this is where we know that there's different types of delirium, where people can be hyperactively delirious. So they have these mental status factors of being confused, inattentive, disoriented, and they're also physically agitated. They're moving a lot. They're getting up and down. They seem to feel very restless. This is where we can see people sometimes put themselves at risk potentially by pulling out lines. We've seen people extubate themselves at times when they're psychomotorly agitated. And then there's the other type of delirium, hypoactive delirium, that we know is less recognized in hospital, because people have this confusion, they have this altered mental state, but they are very withdrawn and quiet, not moving a lot. And in some ways, we often attribute that to recovery from surgery, recovery from illness. And if we don't do that specific questioning, we don't realize what someone's internal world is, that they may be confused, disoriented, hallucinating, having delusions where they're worried that people are out to harm and get them. And so those are the key features of delirium that we see in clinical practice. In terms of delirium risk factors, this is a busy slide, but what I wanted to highlight is one, this fantastic Nature Review disease primer that came out last year in the autumn of 2020. It's a great article. And I also really like how they look at delirium risk factors. Sometimes when we think who is at risk of having this kind of acute mental status change in the context of illness and injury, it feels like a giant checklist, right? People who are older, people who have neurocognitive issues, mental health issues, or substance misuse or benzodiazepine use in the past, right? This whole list. I think this lays it out really nicely that we can consider that almost everyone has some sort of premorbid vulnerability prior to getting an illness. We all do. We all have the potential to develop delirium if there are enough stressors, physiological stressors placed upon our body. So if we become ill enough in the context of enough different medications or substances, or under the stress of surgery, we know that probably the levels of inflammation in our bodies, the levels of different kind of potential toxins, if we're not clearing things well, all of that can affect whatever our baseline vulnerability is. Once that gets to a certain point, that's when we start to see these neuropsychiatric manifestations of that illness. And I think in the transplant literature, we can often see this in liver transplant as an example, where people are in liver failure prior to transplant. They have hepatic encephalopathy because their liver is not able to clear. And so they're already having some of those impacts at a neuropsychiatric level of their illness. And then we add on these other factors that tip them into that point where they manifest the syndrome of delirium. In addition, some of the precipitating factors, right? So if we all have a pre-morbid vulnerability and we think, what are the multitude of factors that can tip us over that threshold that we have? Some of those can actually be the same as risk factors. So we know that things like benzodiazepine use can be a premorbid risk factor, and also benzodiazepine use in hospital can be a precipitating or perpetuating factor related to delirium. It's more confusing if you're in alcohol or benzodiazepine withdrawal, which can also cause delirium. So there's all of these factors that interplay, but understanding what are the premorbid factors and then what are the multitude of additional other factors. For some people, this can make delirium work feel overwhelming because it can feel like, well, anything, all of these things can contribute. I tend to see that as opportunity. So if we can highlight what are 5 factors that for this individual with this brain vulnerability has put them over the edge of developing delirium, we have 5 different places that we can target, and we have 5 different places that we can really make a difference to hopefully improve their delirium. And if we can also see what are some of those premorbid factors that put them at risk, we can intervene even earlier and think of what are specific ways that we have the potential to prevent delirium, right? When we're really thinking about this in advance. Why care about delirium? Again, some of you will know this and some of you will not be as familiar with this literature. You know, I think historically people have said, well, of course someone's confused post-op, that's normal. And to some extent that brief period is, but prolonged confusion, prolonged mental status change is associated with really significant negative impact. So we know that the development of delirium is associated with in-hospital negative outcomes like increased falls, stress, infection, and in-hospital mortality. And we know that in the longer term, individuals with delirium have longer length of stay, mechanical ventilation, ICU stays, and total hospital stays, functional decline. Historically, again, when people had delirium, we said, well, you know, everyone will clear and get back to their baseline. More recent literature that's followed people with delirium out to 1 year and longer post-delirium episode, not in the transplant population, but in other populations, has shown that actually people can have long-term cognitive decline following an episode. of delirium and increased things like nursing home admissions post-delirium as well. Sometimes that's the interplay of people who are more unwell, so who have more of those precipitating factors or who are more vulnerable to start with are more likely to get delirium. And also controlling for those other factors in the larger research studies, we know that delirium is also independently associated with these. Interestingly, as you look at delirium and transplant, a lot of the early work was done in Toronto. So there's studies coming out in the early 90s that were looking at lung transplant patients that nearly 3/4 of them developed delirium post-operatively. There's been quite a bit of work looking at risk factors in different types of transplant, and most of the literature has really focused on lung and liver, which I think if you look at our consultation volumes for delirium, it's probably aligned with that, so less in things like kidney transplant. And the literature within the transplant population mirrors that within delirium research in ICU and medical populations, in that delirium is associated with some pre-transplant factors like poor pre-transplant cognition, longer waits to surgery, I think potentially more challenging or lengthy surgeries, use of bypass, and low cerebral perfusion pressure was a very specific study that was looked at. And then when we look at delirium outcome, again, associated with longer times on mechanical ventilation, longer length of stay, and more poor cognition following transplant. In terms of delirium care, I think we can really divide it into 3 main areas of what we want to do. So as I was mentioning, we want to prevent delirium. So we want to reduce the number of cases. When delirium occurs, we want to be able to identify it. We want to be able to detect through screening and actually clearly diagnose delirium. And we also want to use what we know are evidence-based management strategies to take care of individuals. It seems so simple, right? It seems quite easy, a 3-step thing that we're going to have this huge impact on patient outcome and hospital costs and all of these things. But the reality of delirium care is much different. We know what works for prevention, which we'll talk about, but these strategies are rarely implemented in a fulsome and standardized way. Outside of research studies, we probably detect less than 30% of delirium. And that's even at places like UHN, where we've had some really dedicated education initiatives and focus on delirium. And there's really little consensus about good management. So again, another slide with some main take-home points. So what works in prevention is that we've actually had great studies both in medical settings and ICU settings of what works, and that is a multi-component intervention, recognizing people who are at high risk, regular screening, ensuring that people have sensory aids like glasses and hearing aids so that they can be aware of where they are and their brain can interpret that information accurately, ensuring that people are well hydrated, going to the bathroom, correcting metabolic issues, and minimizing deliriogenic drugs. And we know that when you implement this kind of package, and this study that was published in 1999 out of the New England Journal, so like over 20 years ago, of this multi-component package, this was run by volunteers. This is not a medicalized model of delirium prevention. This is the use of volunteers in hospital to prevent delirium. And up to 40% of delirium cases can be prevented with this type of approach. In terms of detection, there are a lot of different tools for detection that have been assessed in different hospital settings. So there's some specifically designed for general medical units, and there's some designed specifically for ICU populations. The most widely used is the confusion assessment method, which is what we use at UHN, and we have both the CAM and the CAM ICU, and these are standard ways of assessing people for those signs and symptoms of delirium that I mentioned earlier. I wanted to take another pause just to get some feedback to see what people think about using these types of delirium detection tools, whether it goes well, whether it's challenging. How do we do on this element? Always challenging on video to have interactivity. But I would say what we know, I think, I've looked at some of our CAM data locally and the literature more broadly. The CAM and these types of screening tools in research studies have excellent sensitivity and specificity. The challenge is in clinical practice. We are good at implementing them so that they get done regularly, you know, once or twice a day. Twice a day Q-shift is how we have implemented it at UHN. But it's still hard to pick up these differences. And in talking to staff, I think the main challenge of that is it requires us to be able to determine that there's been a change. And when we're only meeting people when they're unwell, it's hard to detect that change from baseline. And when you are a staff who's coming in, and this is the same as the psychiatrist or the physician coming in, we get a snapshot of how someone is in that moment. And it requires a lot of knowledge of that person's you know, pre-morbid state to really understand how different they are right now than that. And I think this is what we'll talk about when it comes to the challenge of COVID, when you don't have family at the bedside. And when people are coming in even more unwell in the transplant context for transplant, it's hard to know, is someone getting better? Are they worse? Are they fluctuating? Is this just them? And how we attribute that can lead to challenges with identification. And then I think really labeling that as delirium is a challenge as well. In terms of management, lots of ideas about what's the best thing to do, not a lot of good data, and very few randomized control trials. I think mostly because the suggested interventions for both prevention and management are multimodal, so not particularly easy to test, although you can do it. And so again, these multi-domain models are recommended, but have limited evidence outside of the ICU. Within the ICU context, the ABCDEF bundle has been really well assessed, and I think is something that we have worked to implement in terms of trying the ABCDEF bundle. They keep adding additional letters, is really about trying to assess and manage pain, get people awake, spontaneous breathing trials, minimizing sedation, getting people up and moving as quickly as possible. And the D is very much focused on delirium assessment, prevention, and management, and engaging families in that recovery process. So this is the type of approach that we know has good evidence. Lots of people have looked at, can we prevent or manage delirium with medications, particular antipsychotic medications, and you will see these used frequently. There's no evidence for the use of antipsychotics to either prevent or treat delirium specifically. And I think this is partly a semantic issue as well, right? So if we're just trying to treat the delirium, you know, the quote unquote brain dysfunction or the altered mental status, we don't change outcome or trajectory by giving a antipsychotic medication. We really need to manage the contributing causes. However, we use antipsychotic medication around this management of agitation and management of distress. So if someone is agitated, hallucinating, having delusions that are distressing and frightening, then we still continue to prescribe antipsychotics judiciously, low dose for the shortest amount of time possible in those particular situations. And I think that this is, you know, hopefully a place that the research and the literature is going, because we don't have any good data on whether the use of antipsychotic medication helps with that. So we know that it doesn't, you know, giving an antipsychotic medication doesn't shorten the duration of delirium for an individual. It doesn't necessarily change its severity. if someone is having delusions and hallucinations and is highly agitated, which might be a risk to themselves or others, if we give a medication then to target those specific symptoms, which is an off-label use of antipsychotic medications in these contexts, does it work? We don't have good data on that. And so really this approach in delirium care is more fulsome than just use of medications. We want to assess and treat any life-threatening causes, optimize recovery, optimize the conditions for brain recovery, communicate well to patients and caregivers, monitor for recovery, get people to rehab when possible, and also knowing that cognitive impairment prior to delirium may impact people getting delirium and also that longer course trajectory. We want to monitor that in the longer term. So that's really delirium pre-pandemic, kind of a lot of what we know about what to do, but how does that change within the pandemic? So we all know a lot about SARS-CoV-2 now. So it's only one of really the 3 coronaviruses that causes this type of severe infection. And we know that we were just talking, I think, before I started about this potential third wave. And so this is all of the confirmed cases per million people in Canada up until I updated the slide yesterday. So we can see that initial first wave, the high second wave that peaked at the beginning of January, and where we plateaued a little bit in the last few weeks. And this was a bit of a viral meme that went around the internet last year about how it started and how it's going now. And I think this typifies what we've learned about COVID-19 over the last 12 months, that it started being very focused on our understanding of a respiratory illness. And we now know how much it affects the body more greatly in terms of lungs, vasculature, brain, gut, all of these other bodily systems. And throughout the last 12 months, people have become increasingly concerned as to what are the neuropsychiatric sequelae of COVID-19. Not only what is the impact of COVID-19 on all of our mental health because of the psychological and situational stressors that we have been under, everyone in the world, but also what are the direct effects of COVID-19 in the brain. And this is still an area of burgeoning research. When we did a rapid review looking at delirium in COVID-19, so we were starting to see that the literature was increasingly focused on these neuropsychiatric outcomes, that people were discussing whether COVID-19 had central CNS effects. We wanted to go to the literature to say, well, what about delirium? What about this construct that the symptom cluster that we already know about, that when you think about the risk is increased when people are socially isolated, not reoriented, in confusing situations, and who have acute illness, surgical intervention during this time, like this is a high risk period for this. When we looked at the literature in that rapid review, there's a clear kind of trajectory, which I think replicates where we all were last spring, of a high number of early case studies and case series that were presented. And these case studies focused on quote unquote atypical presentations of COVID-19. So individuals who had no respiratory symptoms, but were presenting with confusion or delirium or altered mental status or encephalopathy or a disturbance of consciousness, all of these words that likely represent, we felt, delirium, were coming in, but with an absence of respiratory symptoms often, or mild respiratory symptoms, but severe neuropsychiatric impacts. And that then kind of blossomed to some early cohort studies looking at both populations in general medical wards, geriatric wards, neurology wards. Were really interested in this, that we're showing that a significant number of individuals with COVID-19 also had symptoms of delirium. And increasingly, we've seen more systematic investigation of this. This was a study published in the autumn of 2020, looking at delirium in older patients with COVID-19 presenting to emerge. And so what they wanted to look at was how frequently do older adults over the age of 65 present with delirium. And so it's a relatively large study. As you can see, over 800 individuals, a quarter of them had delirium at presentation. And delirium was actually the 6th most common presenting sign and symptom. So again, a large proportion in line with what we know about delirium from the rest of the literature, but presenting in the context of COVID. Among those with delirium, over 15%, that was their primary symptom. So altered mental status was what they were coming into hospital with. And a third of them, over a third of them, had no typical COVID signs or symptoms like a cough or a fever. So this was, I think, one of those early, relatively well-conducted studies that has suggested that this is really something we need to think about and look about when people are coming into hospital. Some of the other studies have tried to look at prevalence. Many of the limitations are that the studies have not been using a validated tool. So again, looking at delirium pre-pandemic, I mentioned how important that concept of detection is. So having a standard and regular way to screen. So only 9 of the 40 studies that we had included in our rapid review that tried to assess prevalence actually used a validated tool to screen. And most relied on either self-report or a retrospective review of medical records. And this is a constant issue in the delirium literature, but the language used to describe delirium varied greatly. The rates of delirium in individuals with COVID differ depending on the study population. There hasn't been a good look at the transplant population yet, but what we do know is that delirium, again, in keeping with the literature prior to the pandemic, is highest amongst those individuals admitted to the ICU, which likely incorporates, again, pre-existing vulnerability, plus the level of physiological stress on the body. Higher among people with more severe respiratory disease. So although delirium sometimes can present as an isolated factor, we know that the rates are higher in those with more severe disease. And the research on delirium subtype that I mentioned before, whether it's hyperactive, the very physically agitated, restless, moving person, or that hypoactive where people are withdrawn, sometimes can look a little catatonic at times. This has been very interesting in the literature. So in the ICU and palliative care populations, they're reporting much more hyperactive delirium, where medical wards much more hypoactive. And I would say that this is also reflected in our clinical practice. When I was on, working on the COVID units as part of the consultation liaison psychiatry team through the spring and summer, a lot of hypoactive delirium, people not eating or drinking, people very withdrawn. And it's hard to know exactly why that happens. And also our intervention and management is really just about treating the underlying cause. And if that is related to COVID infection, where we don't have a lot of option to supportive management for the most part, then what do we do to help people improve? In the literature that we reviewed, only a few studies had a control group, but when they looked at controls, this was mainly in the context of individuals admitted to like a neurology ward who had co-occurring neurological conditions that they essentially could kind of match. Those who were admitted with COVID-19 had higher delirium rates than those without. So the conclusions from that were that this does seem to be quite related to the infection. So how might COVID-19 contribute to the development of delirium? There's really 3 main contributory pathways that are likely and proposed. And I think the right 2 we can talk about because that's where the emerging literature is as well. So on the left, you can think about how socio and environmental risk factors are really increased in COVID-19. So we know that we want to be reorienting people, talking to people, having familiar things close by. That's part of our key delirium prevention and management strategies. So then you can imagine people hospitalized in ICU, surrounded by people wearing PPE, difficult to hear people, difficult to see their facial expressions. So we get exacerbation of these pre-existing sensory and cognitive impairments, and we effectively really remove people from anything familiar. So that's disorienting in itself. And how do we mitigate that during this time where we're trying to mitigate infection and spread? The second pathway is really that COVID-19 complications and management can contribute to overall physical illness and physiological impact. So ARD, acute respiratory distress syndrome, common with severe COVID-19, can lead to hypoxia, acidosis, respiratory failure, also associated with delirium. Prolonged ICU admissions, use of ventilation, sedative medications, also associated with delirium, as is systemic inflammation. So all of that those pathways may contribute to increased delirium in these risks, in these populations who are already at risk. And I think in addition to that, trying to restrict people's movements as well has been a real challenge, right? That level of sedation, and we know from that ABC bundle, trying to get people up, trying to get people walking and moving is a key way of preventing and managing delirium in these populations, but we're not able to do that as much when they have an infection like this. And then there's been a lot of work done on whether SARS-CoV-2 can actually directly enter the CNS. And there are some theories that this could be through the olfactory nerve, and that's why there's anosmia is very common in COVID as well. So is that the route that it could enter the central nervous system and the brain? And also whether there could be increased transmission at the blood-brain barrier, and so that the blood-brain barrier becomes more permeable. And then you can see how that might intersect with these other complications of COVID, that there might be more transfer of inflammatory markers into the CNS. And so there's been work done to look for, SARS-CoV-2 within CSF and the like. In terms of outcomes, very few studies have looked at outcomes in COVID-19 and delirium. I think because it's early days and things take, although there's a real preprint culture right now, things take a while still to get into the peer-reviewed literature. But the small studies that do exist report associations between delirium and, again, poor clinical outcomes that are very aligned with what we already know from the general literature: increased length of stay, ventilator use, mortality, and cognitive or dysexecutive symptoms at discharge. Not too much in the transplant-specific literature. When you do look at the delirium literature and transplantation, there's really just case studies. And I think, as a community, really focusing on, one, how are we going to protect those who have already had a transplant, and how do we ensure that transplantation continues during this period of pandemic has been the clear priority over the last year. And I think that going forward, thinking more as that hopefully becomes more consistent going forward, that we can start to look at some of these other outcomes going forward, because we know that individuals with transplant are high risk for delirium. The papers that did exist, again, quite limited case studies and case series looking at acute encephalopathy, which is often a term that's used synonymously with delirium. Technically, they're a little bit different. There's some writing about this, that acute encephalopathy is really like delirium when we know that there's a central CNS cause. We know what the etiology is rather than that multifactorial type of look at that. So this was a case study of a 67-year-old man admitted with respiratory illness, which was COVID, over a year. He's about a year and a half post-heart transplant. And then the other case series was individuals receiving lung transplantation for COVID infection, and that some of them had had, at least one had had symptoms consistent with delirium preoperatively. What do we do? Again, no trials, limited evidence to guide practice. The majority of the recommendations coming out on what to do with delirium and COVID-19 suggests using standard types of delirium management approaches. And numerous organizations, if you take a deeper dive in terms of specific guidelines, medication use, those types of things, this has been a work in progress, as also management for COVID-19 infections has altered over the period of time, right? We're talking about using hydroxychloroquine back in the day, and like what were the interactions of that with other medications. This is what some of these guidance pieces were coming out within the spring and summer. This is really shifted into kind of just use good delirium management more recently. And so the expert consensus is for delirium prevention, think about how do we implement the things that we know work to prevent delirium in the context of COVID-19. So we know that reorientation, helping people feel not socially isolated and connected is important. So can we use electronic devices to do that? Can we have badges and pins that show our entire healthcare worker faces so that it's not as disorienting through the screen? And we saw some of that coming out of New York and Italy earlier, where they had large stickers of their faces on their gowns. Ensuring that we're doing accurate, regular delirium screening is important, and that the other principles kind of making sure as much as possible that people have sensory aids. Can we get people's hearing aids and glasses dropped off at the screening desk to come up to the floor even when people can't have visitors? Ensuring that we're managing pain, fecal and urinary retention, avoiding physical restraints, and promoting early mobilization. When delirium happens in COVID-19, it's not just because of COVID-19, although that is a factor. And so it's really important that we continue to work to identify and treat other underlying contributing causes. And the pharmacological therapy of COVID-19 delirium has continued to focus on agitation and psychosis, with most, not all, but most suggest avoiding the use of anything sedating where possible. And again, when it's needed for distress or agitation, to be judicious and conservative in the approach. There's been some question whether melatonin may be anti-inflammatory and play a role in optimizing sleep. I think most of the literature around that has been more opinion piece and commentary and theoretical possibilities of it being effective, but something to think about. And there's really insufficient evidence to suggest one medication for delirium management. As Susan alluded to at the beginning, I think the other things are, how do we capacity build in this area and take advantage of some of the other resources that are being developed out of our area? The Regional Geriatric Program of Toronto has excellent resources on their website. So they've developed, this was very early on in April to June of last year. And I think the good quality of what they've put together is really helpful. They have communication tips for dealing with older adults with delirium, again, helpful in all populations, not just older adults. They have a COVID-19 delirium prevention toolkit. So how are we implementing some of the things that I talked to you today within the context of a pandemic, reduced visitor policies or essential care providers? And how do we provide, to me, I know there's a focus on senior friendly care. It's the Regional Geriatric Program, but most of these things are good for everyone, right? That it's not just seniors who are at risk of delirium, especially in more medically vulnerable populations as well. Ontario Health Delirium Quality Standard will be released later this month. And also it's World Delirium Awareness Day coming up on March 17th. There's going to be some UHN focused activities around that, like the background on your computer will soon change to a delirium focused one in the next few days. But I think the more that we can think about delirium and work on its prevention and management, sometimes it's so common, it feels overwhelming. And when it's so common and there's so much that we can do, I think if we can really target those strategies, we can have a huge impact on patients, families, outcomes, and the system, given how much of a cost delirium is. In our clinical context and transplant, I just want to plant the seed to consider COVID and the differential of individuals presenting with delirium and confusion, even pre-transplant. All post-transplant patients, as you know, are at high risk for delirium. And thinking critically, again, all of our brains are tired. All of us feel quite, a lot of us feel quite overwhelmed and tired right now. But the more that we can think about how does this context that we're working in, that we've habituated to in a kind of tired, exhausted way, how might those policies be impacting individuals getting delirium and its severity? And really, in your post-transplant readmission, all of those apply, right? All of those situations are different. And I think for some of the post-transplant people who are readmitted with illness now, this is a totally different experience for them. If they haven't been in hospital in the last year, what a different world this is, and how it might feel much more scary, right? Much more disorienting and much different. And so in some ways, they may have a really different perspective that would also put them at delirium risk. So in terms of conclusion, delirium is emerging as a common kind of neuropsychiatric symptom of COVID, although it's not reliably identified because we don't screen well and we don't have a consistent terminology to describe it. The contributors are likely multifactorial and may include those environmental factors as well as direct deliriogenic mechanisms in the CNS. And that continuing to use multimodal interventions for prevention and management are likely the best strategy that we have right now, although the strength of the clinical recommendation is lacking given how novel this is. And I just wanted to thank everyone who worked on the COVID-19 delirium paper with me. I learned a lot about doing a rapid review in a rapid evolving area, which was hard to keep up with the literature. And then all of you and my colleagues at UHN and U of T, because I think this is a place where we really work to implement best evidence with best clinical practice. And that's a pretty fantastic place to be. So thank you, and I'm happy to take questions.
Oh, thanks so much, Katie. We will take questions. Anna has reminded us in the chat box that the session's being recorded. So if you're asking a question, that's going to be recorded, and then it'll be available for people who are off service right now. So that was a really helpful overview of a complex area that we don't have enough data on.
Yes, so thank you, Katie. I think Atul has raised his hand.
Yeah, thank you, Katie. That was a wonderful presentation. Really much appreciated. I have, I'm not sure if it's a question, but just to ask for your input maybe, because we have a patient right now who has like everything you described in terms of risk factors. So he's an elderly gentleman who just got a lung transplant, and unfortunately he developed COVID like immediately post-transplant. And one of his major issues, he's still in the ICU, but one of his major issues has been delirium. And the other issue is that like his family has kept wanting to visit him, and that's been like super challenging because of the COVID. So I don't know if you have any thoughts on that or comments on that.
Yeah, so I have not been on the service lately, but I know that these types of situations are coming up. So one, I think this is a great opportunity for collaborative care. And so, calling psychiatry and involving all of the other healthcare professionals. And I think that's what really comes up in good delirium care as well, is that how much of this is a collaborative plan of action between patient, nursing staff, physicians, OT, PT, all of the other healthcare professionals, so that we have a consistent plan of what to do. when there's a lot of risk factors, like I said, I think what's really helpful is to look through all of those. What are the kind of premorbid vulnerabilities? What's happening now, and what is modifiable or not? Because some things are not going to be changeable, right? Like if he needs to be in the ICU, he needs to be in the ICU.
Yeah.
And then working, I think, also with hospital policy a little bit to see in these particular situations, is there anything that we could do differently and safely to have visitors or to help facilitate that as well, whether that's electronic or in person. And I think when you have an older adult who's confused, sometimes those electronic means are not as, they're more confusing at times. And so how do we work with that? And I think the other challenge with transplant is often their families are not local, right? Are remote as well. But when we can have some element of essential care partner in or visitors in, that can be helpful. So I think it's really about taking a systematic approach, and maybe having, if it's prolonged as well, having a care planning meeting, and also even when people are not available to be there in person, incorporating families as much as possible, because they also know what the person, and you can ask the person what they really like and what they miss. Photos, music. The more that we can use all of the senses and multimodal things as well, right? The things that are familiar and comforting to kind of, again, a very unscientific sort of thing, but to wake up the parts of the brain that are in touch with who that person is, where they are, can be effective.
Yeah, makes sense. Yeah, very, very helpful. Thank you.
So I guess there's a message from Christina Rivas. Can you comment on the overlap between depression and delirium in this patient group? Does a prior history of psychiatric disease affect the incidence or management of delirium in this population?
Yeah, I think that's a really important question. So there is some literature that would say that says that people who have pre-existing mental health issues may be at increased risk of delirium. I don't think it's not a particularly clear link at times, because it's confounded by a lot of different things. I think where it's really important to think about, does this person have delirium, depression, or dementia? Because all of them can look quite the same. And in psychiatry and these mental health diagnoses, we're diagnosing based on clusters of symptoms, what people are presenting with. So I think often people who have delirium have emotional or affective changes. They may be more tearful, they may be more sad, and that also goes along with depression. But they're clinically different in that how quickly the onset is. Again, when you have a prolonged postoperative stay, that becomes more challenging to differentiate a little bit, but usually you see that acute onset and that fluctuation. And those other features, inattention is really critical in delirium in terms of diagnostic criteria, where that's not as common in depression. The important thing to try and clarify those, and you might, is because of what the management is, right? We would not be prescribing psychotherapy or pharmacotherapy for depression in someone with delirium. And so getting and understanding that history is really important. But a lot of it has to do with what I said, is that how are they doing at baseline? When was the change in status? What precipitated that? And then what is the course of symptoms? But often we will take delirium as kind of the more pertinent diagnosis to say, how is this going to clear over time? Adding another medication to the mix can sometimes make things worse. And we also know that our medications for depression take weeks to work, right? And so making sure that that delirium is clearing and we've optimized all of those other things can be important first.
Very good. So just from my understanding, so if you have delirium and you are on antipsychotic drug, and we think that the antipsychotic drug is contributing to the delirium, right? If we take the patient off how soon should we anticipate the improvement? Do you have, can you give me some guidance?
Yeah, so I think in your question is, so generally people who are, if people have a like schizophrenia or a primary psychotic disorder, and they're on an antipsychotic, we would recommend that they continue on that post-operatively or post-illness if they develop a delirium. So generally, we're not as concerned about antipsychotics as the precipitant of the delirium. We're thinking of things like benzodiazepines can worsen, so other psychoactive drugs. So things like some of the Z drugs, like new onset of zopiclone or use of benzodiazepines that often get prescribed in hospital because people are agitated or they look anxious, but it's actually the delirium. So those are the things that we think of as psychoactive drugs that are more likely to precipitate or perpetuate delirium. The antipsychotics less so. The judicious use of antipsychotics is more that when we initiate them for psychotic symptoms that are part of a delirium, so hallucinations or delusions, we just want to use them for a short period of time and discontinue them as soon as possible and taper them. Because what we see is that people remain on those medications, low doses of quetiapine or olanzapine at transitions of care, and everyone's worried about stopping them because everyone's like, they must be on it for a reason. And so we see people who are started on an antipsychotic for psychotic symptoms in the context of a delirium who continue on that over time. And actually that's the greater risk, that those medications are started for delirium. It's not clear what the indication is at that time, and then they continue on it and they end up being on a medication with relatively high risk of metabolic side effects and other side effects in the longer term. When we discontinue things like if people have been just started on a benzodiazepine post-operatively, and we worry about that's precipitating delirium, you would expect to see that clear within kind of a few days if that's what's happened. If they've come out post-op anxious, someone started a benzo, they're getting more and more confused, stopping that is important. If they've been on a benzodiazepine long-term, have to be very careful, right? That we don't put them into benzo withdrawal. So it's always this kind of balance that's quite challenging.
All right, so we have 1 minute left. I think Nikki had a question.
Hi, thanks so much. That was such a great talk. I just had a question. Often we have patients who are coming out of the ICU after being on, weaned from the ventilator using dexmedetomidine more commonly now. And then as they're weaned off of that, they're started on clonidine. So can you just talk about weaning the clonidine and give us some tips about that?
So I think there's a few things, and I think this is where we really have to work closely together. Often it's unclear a little bit whether the clonidine's been initiated for hypertension or agitation when they're coming off, right? So I think that when we're talking to the colleagues coming off the vent saying, what's the indication? Why did you start it? Because sometimes people have made a parsimonious choice and said, let's use clonidine to target both of these issues. And, then we don't want rebound impacts on blood pressure, right? So generally the plan is to go slow. So people are often on kind of frequent daily, TID or BID dosing of that. And so kind of gradually tapering it down and seeing response. But I think ensuring that we really understand what was the indication for initiation is really important with clonidine. Because a couple of times we've thought it was started for that purpose of kind of weaning after the dexmedetomidine has been on. And then we actually learned that they were having a lot of trouble managing blood pressure, and that's why it was there. And so I think those are the key things to understand. What's the indication? And then that's going to affect how rapidly we can taper.
Right. Thank you very much, both for a great talk and a lively discussion. Please, if you want to claim the credits, fill in the survey. It will just take a minute or two. And see you guys next week. Thank you, Katie.
Great. Thank you very much for the invitation. Always nice to work together with you guys. Bye.